Hi, I'm Mina Malik Hussain and you're watching The Coffee Table, and today we've got a wonderful show for you, which we always do. But you know, every time I'm freshly excited about it because today we are going to be talking to the founder of one of my favorite charities, people who are doing fantastic and important work with expecting moms, with childbirth, and with newborns. And I love babies. And for me, this is something that's very close to my heart. So I'm delighted today to welcome remotely on this very safe coffee table, Neha Mankani, who is the founder of the Mama Baby Fund and is also working with the Global Health Directorate of the Indus Health Network, setting up their midwifery programs. And Mehreen Shahid, who is the founder of Safe Delivery, Safe Mother, and is a public sector advisor. Hello, ladies, super ladies. Welcome to the show.
Hi. Hello.
I'm so excited to have you guys here. And as Neha knows, I've been sort of wanting this to happen for like donkey's years now. And I'm like, I want to talk about the babies. I want to talk about the moms. I want to make things safer for everybody. And so I'd like to sort of start at the very beginning. And Mehreen, I understand from the statistics that unfortunately, for a number of reasons, the maternal mortality rate is one of the highest in South Asia and also globally.
I think what's important to highlight is that a vast majority of the instances of these deaths are preventable. And in Pakistan, we lose about 14 to 16,000 mums every year, which is a huge number.
That's massive, because I think, again, from statistics that I've read, we have 5 million births a year. And half of those are home births, and that's something I want to talk about in a minute. But that's an astonishingly high number of women. But before I get into that, I wanted to ask, could you tell me the story about Safe Delivery, Safe Mother? What led you to it?
So I think what happened is that I've always been interested in public health and been doing work in this area specifically. And I was working in New York at the time. And wahan par, when I was there, to be really honest, I just kind of wasn't feeling the passion. I was like, no, like I really want to go back. I want to work within the public health field, but exactly what am I going to do? So that's where my interest started developing in maternal health. I looked at the statistics, the facts. That's exactly what kind of really stunned me, that, you know, it is preventable. There's so much that's left to be done. And that's when I came back, and then we founded a Safe Delivery, Safe Mother in 2017 with the goal to kind of work more in rural areas and also be able to equip what you call your skilled birth attendants across the country eventually.
Yeah.
Obviously,
that's also something I want to cycle back to. Many things to talk about. But Neha, what is it with New York? Because you were there as well, weren't you? And then you also sort of, that was your path as well. And I'm always interested in the paths people take, because, you know, here you were at Columbia, and then you too felt like this pull to do something hands-on, on the ground, to make a real difference, a tangible, immediate difference. And so tell me about Mama Baby Fund's journey.
Right. So basically, yes, you're right. I was studying in New York. I was studying public health. A lot of my focus was on maternal and reproductive health. And then I came back and I worked in public health for 2-3 years more. And I had been doing that before also. Yeah. And I just felt like public health, because it's so frustrating, because the change is so slow. I think to get rid of that frustration, what I wanted was to have a technical skill related to maternal health. Yeah. So I looked around, and then I found this midwifery school, and I started going to midwifery school in 2014. And it was actually really fun. It was everything that I thought it would be. But part of what happened while I was in midwifery school was that I saw that financial issues were a really big part of what women were experiencing in the maternal health process. So, you know,
and at this point, I just want to sort of interrupt you for just a second to point out that you were doing midwifery school at a public hospital.
No, it's a non-profit, it's a charity hospital.
Okay. So it's a charity hospital, so which means that the majority of the women that you were working with as a midwife and after your training were lower-income women.
Right. So the hospital is specialized hospital for maternity care, and you know, it's subsidized rates for everything. Yeah. But even then, we would see so many people who would say that, you know, we just don't have, like, baby needs to go in incubator. We just don't have the money. Don't have the money for one blood test. Don't have the money for antenatal checkups. And there was just a lot of desperation in that. So while I was there, you know, I just started just from collections around family and friends. I started helping people out. And I think when I saw the need, it just became a lot bigger. So I think this started in 2015, and here we are now in 2016. I got it registered, and then it's just onwards and upwards since then.
That's quite true. And it's so heartening to see the progress that the Mama Baby Fund has made. So I've been following it from very early on. And it's such vital work. And Mehreen, tell me more about Safe Delivery, Safe Mother. I think that the name in itself is really clear. Safe Delivery means a safe mom. So where are the areas that Safe Delivery, Safe Mother works in?
So when we started out in 2017, we won a competitive grant from the US, which helped us kick off.
Yeah.
And when we started, so I was looking at exactly where is the most scope for impact.
Yeah.
And as you've already mentioned, right, about 50% of births take place at home in rural parts of the country where women do not have access to a healthcare facility. Or even if they do, they're either unable to go there, either they don't have the money, or there are multiple socioeconomic constraints, which I'll talk about later.
Yes.
So what we did then was thought, okay, where do we fit in, right? So what we do is we work with skilled birth attendants, essentially that are government deployed.
Okay.
Because they are then functional in these health facilities. They set up community clinics in rural areas, and from there, women either come to them or they're able to access them at home. And that's
Is that the
main
same as a lady health worker? Is that the same as a lady health worker?
A lady health worker. So no, a lady health worker is not allowed to conduct deliveries. Her mandate is essentially to raise awareness on maternal and child health. The skilled birth attendants are essentially your community midwives, your lady health visitors, who are then trained and allowed to conduct deliveries.
Right,
so that is
specially
the main area that you want. Yeah, they're trained by the government. They're certified, but I mean, Neha would agree. A lot needs to be done in terms of quality and training and skill and getting them to that level and all of that. Those realities obviously remain on the ground.
No, but it's, and I keep sort of saying, are they trained? Are they trained? Because there's this sort of common idea that because, well, so many women give birth to kids and it's a natural process and so many women do it, and what's the big deal? And the dye, for example, is sort of seen as a kind of jack of all trades, kind of universal person who can just hop in and sort of help you pop that baby out. But it's much more complicated than that, and you need a skilled, a trained birth attendant with you present to kind of navigate whatever is going on, because it's really not as straightforward a process as a lot of people seem to think it is. So
absolutely, and I think the thing to kind of highlight is that the numbers are staggering, right? So the leading cause of maternal mortality is called postpartum hemorrhage, which is excessive blood loss. This is a global leading cause.
Wow.
In Pakistan, this is about almost 30% of deaths. And if you break this down further, about 70 to 80% of these deaths can be prevented. That's what's mind-boggling, right? Because you can do it, but it's not being done.
Yeah.
The recognition is there, the evidence is there, the data is there, but it's not happening.
But why? These sort of things. It's like, and I believe that there's a drug for it, right, to stop the hemorrhage. Misoprostol, am I pronounced right?
There's a drug called misoprostol. Yes,
I got it wrong.
So there are cost-effective techniques. Yeah, there are cost-effective techniques that you can use, and misoprostol is one of them, because like 3 tablets cost about 30 rupees, which would be what, like $0.06 something dollars. Yeah. And if women are trained, skilled birth attendants are trained to administer that effectively, that's one of the ways that can be prevented. Yeah. And, how that can happen. And the government, especially I speak for Punjab, a lot of the advocacy has happened. It's on the essential medicine list. All of that is happening. It is readily available in some basic health units. It is not available in some. But a lot of the advocacy work has been done around the drug.
That's promising. We're going to take a very quick break. Back to this fascinating conversation. Stay with us. Hi, welcome back to the coffee table. We're talking to Neha Mankani from the Mama Baby Fund and Mehreen Shahid from Safe Delivery, Safe Mother about the maternal mortality situation in Pakistan and the amazing work that both of these organizations are doing to try and alleviate it. So Neha, tell me, you've been trained as a midwife, and from what I understand, a midwife is not a dai.
It's not a dai. Midwife is not a dai, but the issue is that there's no word in Urdu for midwife. So a lot of times it becomes synonymous with dai.
Right.
which is really problematic because there's a very big difference, and midwives take this difference very seriously because midwives are trained. Um, and dyes are basically what we are trying to get women not to use as healthcare providers.
So what's the difference?
So difference is that a dai is a traditional birth attendant. Usually it'll just be women. I'm sure Mehreen can add on to this, but women who have just been in communities for really long, are trusted members of communities who do conduct deliveries. They do it at home, and they have that kind of rapport. We'll do barter. You don't always have to pay her. She'll take a bit of your crop. She'll take a goat, like things like that. So, and the issue is that a lot of these communities we work in, Dai culture is like really strongly embedded in it. So even in places where you give women access to really to quality healthcare services, a lot of times the families and everyone will just say that we feel more comfortable with these traditional birth attendants. And at the labor room that I have started with the Indus Health Network, it's in South Punjab. And we get what the midwife team calls a die handle case all the time. And it's women who come in really bad states after dyes have done whatever they could. They give them a lot of drugs. Sometimes we have reports of women, Kidai put her foot on my uterus and tried to push the baby out, put herbs inside. And so a lot of disastrous things. And when everything doesn't work, the woman will end up with us half dead, the baby's passed away. So dyes are actually doing a lot of damage to these women.
They're just taking to sort of think of a dai pulling a baby out of because I think that this is a really important thing, and I'm sure Mehreen, you can sort of add to this, is that a lot of times there might be a sort of trained medical facility, but women and families are reluctant to use them. So do you feel like all of this sort of awareness work has it addressed these concerns as well? Because there's a matter of trust. And do you think, but where does it come from? Like, surely families would want to sort of rely on a medically trained professional. Like, why are they so reluctant?
Yeah, I think I want to, in addition to what Neha has highlighted, it's important to kind of work with these dyes and take them along. It's very critical. Because when they're at odds in the community, then that becomes very problematic.
That's
it's
true.
Die over the midwife, die over the LHV.
Yeah.
So I think what's happened is that this is not about women at that level wanting to take medical care. There's a lot of socioeconomic elements that come in. And for example, like I have sat in communities where the mother-in-law told me, I've had 11 kids, where have you come from? I mean, I can't say, no, that's her reality. Right. So usme usko batana ke why medically it's important is one issue. Addressing socioeconomic constraints is another issue. And that is one of the key things that we work at SDSM. That's one of the key things we focus on. Yeah. In fact, we've designed curriculums on that. Because oftentimes that's the key thing that prevents women from seeking access, whatever that is. And that is the main thing that we also need to work on. And the dye culture obviously is part of that.
Yeah. So it's a sort of two-pronged where dye culture is so deeply entrenched. And again, one of those things, like if you've had an easy delivery, then your experience tells you that this is not such a big deal. But when deliveries are complicated, that's when it becomes an emergency very fast. So it's dye culture, and it's also money, quite frankly, and people who and women thinking that this is going to be really expensive, and I can't afford to have an LHV or a trained midwife in attendance. And also, there's also a family factor. Then do you find that either of you in your work have you seen that there's a lot of pressure from mothers or mothers-in-laws or husbands that no, this is the way that we're going to do it, and maybe moms themselves do want a different way or different birth experience?
I think a lot of it is also around the mobility that women have. Right. So, the fact that the dai will just, often just come to the house, someone can just bring her there, means that women also, they can just stay at home and they don't have to go anywhere. So I think a lot of it is around mobility. A lot of it is around, this concept of communal ownership of women's bodies where women don't always make decisions around their healthcare themselves. And cost is a really big thing, but dyes are also, from what I've seen, dyes are also expensive. They take a lot of money. They do take money. And a lot of times people will come to us and they said that when we don't have money, the dye will just take something else from our house and she'll say, this is my payment. And when we started this labor room, for example, it was a free service, and even then we had trouble getting people to come in. But so I think a lot of it is around establishing that trust so that women think that this is a safe option for me also. And I think one other issue that comes up with LHVs and midwives that Mehreen, you might also have seen is that they're also much younger. A lot of times they're very young. Midwives jo hoti hai CMWs, they start going to midwifery school when right after, metric or inter. So a lot of times when they graduate, they're just in their early 20s. So we'll have these little girls who are actually really skilled, but I've had women say that, I don't want this girl in my delivery. She looks like she's like 12 years old, so I don't want her to do it. So there's also that concept in their heads that, a person who's going to deliver your baby has to be older and has to have like 20 years of really like community experience. But we're trying to like dispel all of those myths, and and it's a lot of it is just leading by showing them examples of that, we've done all of these safe deliveries. Another thing that Mama Baby Fund is helping with is, women who deliver safely with the midwife, then they'll get a care package to take home. So that's a pull that, if you deliver with this midwife, you'll get a bed and clothes and things like that. So multiple factors trying to get them to come to us.
How successful has the package been? Because again, that's something that's so lovely, because with the mama, well, you tell me, Neha, tell us. I won't tell you about it. Neha should tell us about the care package.
So the care package was something that, it was just how it started was, it was obviously a secondary thing. Like most of our work is financial, but how it started was that we were giving people clothes that people would give us, things of their old, like that their babies had outgrown. We were giving those out in hospitals, and I felt like it was really well received. Like people were happy to take other people's, like pre-loved clothes if they were in good condition, just to have something for their baby. And when we started going to Lady Dufferin was still okay, but we would go to civil hospital and places like that, and babies would just be, when they were born, just wrapped in an old dupatta, like nothing to wear, winter maybe nothing to wear. Especially in these public hospitals, like especially rural areas, mein kuch bhi nahi hota tha unke paas. So the care package campaign, it just started, one day we just tried it on Mother's Day a few years ago with the Patients Aid Foundation at Jinnah. And we did it as a pilot. And when we saw how well received it was, we were like, oh, this is amazing. So what we'd usually give people is a bed and a few sets of clothes, diapers, sanitary pads for the woman, so we'll give them like a baby Panadol. We change things around depending on the season, blankets for the winter. And people love it. People have just taken that one package and said that, this means so much to us. And same is what we're seeing at this midwife-run labor room, that people actually coming in for that package and they know about it. So even if the first time they come to the facility is to give birth, they'll tell us that, oh, where's the package? Make sure that I'll be getting that. So it's a very small thing, but it is a really big pull for someone who doesn't have all those things ready, right?
That's absolutely true. And what seems like a small thing and this is a sort of successful tactic that people have used, governments have used for getting kids in school as well, is to give them ration packages and say that, well, if you send your kid to school, then we will give you groceries for a month. And those kind of incentives, I think, work really well in a place like Pakistan, where, like Neha has just said, a lot of newborns have nothing. They're just wrapped in an old dupatta, and that's it. And sort of, it's shocking, but it's something that we all need to be really mindful of, that there's this massive disparity in outcomes for so many mums around this country. So Mehreen, tell me that the work that SDSM, I got that right, is doing, most of your work, you said, is in Punjab. And I remember that in the beginning of the show, Neha mentioned how it's really slow for policies to kind of trickle down and be implemented in actual practice. So what's your experience with that, with SDSM?
So I think with us, what's happened is we've developed a very good rapport with the maternal and child health department who we directly work with here in Punjab. And in fact, they really appreciated and acknowledged our curriculum on postpartum hemorrhage. And they incorporated our curriculum into their official refresher trainings, which applies to about 8,000 skilled birth attendants across Punjab.
Wow.
So that was a fantastic, I think, sort of victory for us, or like a good synergy moment as well. Just maybe we're like, we'll still go district by district, keep training. And then because that curriculum is all part of their refresher, the cycle kind of continues. So I think I speak for Punjab. There's been very good uptake. There's been good recognition. There's been a good collaboration that's happened. There are obviously a lot of areas that are still needed. But I do think that we're on the right track, though, because you see, when we look at the data that they have, the information that they have, the way they facilitate us. So what we do is a very cost-effective model.
Yeah.
We choose their workers. We go train in their basic health units, in their hospitals. But those things also really help. And that has been a fantastic, I think, collaboration for us as well. And, to also add to kind of what Neha talked about with reference to her care package, she's talking about giving it to the end beneficiary. We've developed a safe delivery kit, which is about $1.5 to $2 with misoprostol tablets. And we've given it to these women, these LHVs and midwives. And that really helps in uptake. Because again, back to Neha's point, they may even be wanting to do it. But another main thing you have to see is I've taught them the skill. What's the uptake? What's the integration? What's the use on the ground? And these tools kind of help them do that, because otherwise they're like, oh, we don't have tablets. We don't have a sheet. We don't have sanitary napkins. So we've taught them a lot of these things, and the government has facilitated us. And we're hoping, obviously, that the journey continues, because one of my main achievements one of the main things that I'm looking to achieve over the next 2 years is that we should be able to at least have covered more than half of all districts in Punjab.
That's fantastic. More than half is excellent.
The majority of the delivery. Yes, because then we will have targeted over 1 million annual pregnancies and deliveries. Yeah. Because so far we're targeting about 300,000.
300,000.
Yeah.
Okay, we're going to take a quick break and come back to this wonderful conversation. Stay with us. Welcome back to the coffee table, where we're discussing maternal health and maternal mortality. And these are all tongue twisters, so I'm going to just start talking to the others now. So, Mehreen, in the break, we were chatting about silos. So could you tell me what a silo is? Not a grain storage unit, I'm told.
Yeah, so in the context of our work, I meant to say that, a lot of the initiatives are doing brilliant work across Pakistan, but doing it quite independently.
Okay.
Not because of any fault of their own, but there is a desperate need for partnership and collaboration, right? And when you have that, then the impact of that is massive. So giving a small example, if Neha has a labor room set up in South Punjab, then a lot of the people that we refer to could be referred to that labor room, right? Other than the government ki facilities. So these are small examples, which eventually in terms of scope and impact are massive. And I feel that there's a lot that needs to be done on the policy advocacy side, as well as on implementation on the ground.
Right. So what would fall the ambit of quality, for example?
Fall under the ambit of quality is when you deliver, when a mother goes when an expectant mother's needs are fulfilled, they can only be fulfilled if she goes for regular antenatal checkups. We advise that she should take a minimum of, so she knows what her needs are, her health needs, dietary needs. If she's got any high risk pregnancy factors, that is the point where this is highlighted. Then at the point of delivery, it has to be hygienic, clean, safe, in a place where the woman is not going to get infected, or neither will her baby suffer. And then for postnatal care, where you're able to see how the child is, what the mother is going through, bringing in those elements of PPD, other mental health elements also come in addition to maternal health, is the entire value chain of healthcare maternal health is what I call it.
Right.
And that is what we need to kind of look at and see where and exactly what's happening on the quality side, where there's obviously a lot of scope for improvement.
Yeah. So, Mehreen, we've been talking a lot about sort of safe environments for mums to give birth in, but then it's also such a complicated thing, isn't it? Because mums also need to have prepartum, nutrition awareness, and to be able to, like you said, if they have these sort of prenatal checkups, would they do that at the basic health unit in their area? Is that where these sort of things should ideally be happening?
Yes. So what should happen is that a woman should identify the closest basic health unit. And that's where she goes. She's the lady health visitor. And then that lady health visitor or midwife is going to be the person who's going to be delivering her baby. Right. So the entire 9 months should be spent with her. And that woman then gets more detail about the situation of the pregnant woman, what her needs are. And then based on that, then decisions are made.
But then that lady is not a doctor. She's not a doctor, basically. So then would that lady health worker then know how would they know that, okay, now you need to be referred to a doctor at a hospital, for example?
So lady health visitors and community midwives are trained primarily. They go through midwifery course which is about 1.5 years or 2 years. I'm not entirely sure. They go through that, and
Okay,
they're
that's
equipped
long.
and trained to handle antenatal care and deliveries. And they also know exactly when they're able to handle a case, and when they're not able to, then they refer these women. So, for example, with bleeding, they've been taught very clearly to see and identify what is excessive blood.
Yes.
Once they know that this has happened, they will refer the woman to a higher healthcare facility. So these women are essentially trained to do exactly this.
That's fantastic. That's a really commendable level of skill and training to have, to be able to recognize these things and obviously work under an incredible amount of pressure in an emergency situation. That's fantastic. I'm so proud of them.
We even teach them techniques to prevent, for example, excessive blood loss or PPH, which cost up to like $5, not even more than that, where they can use the local facilities and the local resources that they have, and they can either prevent it or delay PPH. And honestly, like the feeling that you get when you see these in practice, for me, like I've worked in so many different countries, this doesn't match. Because you're like, these women are actually like, implementing what's been taught on the ground, and the evidence speaks for it.
Yeah. And there are obviously women who are then waited, because when they have these retrainings, then they must come back to you guys and tell you about the instances in which they were able to use the information that they have and sort of make a difference in another woman's life.
Absolutely. At SDSM, we do extensive monitoring and evaluation. So we do follow a district for 6 to 9 months, where we do a range of follow-up tracking of the reporting of the use, focus groups. So there's a bunch of things that we use which shows us what the improvement has been. And I think monitoring and evaluation is massively needed in this field, because we don't even have district level maternal health indicators. The day we have that in Pakistan, we will be able to know which districts are lagging, which need more attention, because Pakistan currently reports one national figure.
So that sounds like it's also an issue of data collection.
Absolutely. It is of data collection, and it's also of data use.
Okay. So it's like a two-pronged thing. So Mehreen, since we are in the middle of a pandemic, how do you feel COVID has sort of affected the outreach that basic health units have and, your trained birth attendants have? I mean, I'm sure that they've probably had to kind of retrain or modify their techniques. Like, what are pregnant women in rural areas doing now? Because this is like a fresh wave of difficulty.
How the pandemic has negatively impacted this scenario is that a lot of the women are then not going to healthcare facilities, or they're kind of staying in and hoping for this to pass. So for that, what we've kind of told these women is that they need to stay in touch. If they need to make home visits, they should be able to do that. And then what we did is we also started a PPE kit drive. So the women that the health workers and the LHVs that we've trained, we provided PPE kits to them at basic health units, because women come to them, so they're also at risk. So we provided them with those kits and those sanitizers and everything. So because eventually, with reference to delivery, that's not something that can happen remotely, right? A woman physically have to come and physically have to do that. So that is part of it.
So basically, one is just doing the best one can, really, in the given situation.
Absolutely. This for maternal health, it is negatively impacted on the ground, but it is what it is right now. For example, we can't go in the field very readily. We can't do a lot of those trainings. Remote trainings is a bit difficult with that level of literacy. The uptake is a bit difficult. So these are realities that exist on the ground, which you have to deal with, which you have to kind of plan for and then move forward.
So sort of coming back to what we were saying about data collection, what are the advantages of having that kind of data?
So how it helped us, for example, is when we went to a district and we did training, then we followed that district for about 6 to 9 months. What it helped us to identify was what are the primary constraints that are hindering uptake and integration of the taught skills. So to give a very specific example, we focus a lot on socioeconomic beliefs. So then we used to sit with these women at the end of the 9-month mark and tell them, okay, these are the beliefs and issues that we talked about right at the outset. What have you dealt with? How many have you overcome? So for example, there are notions of... So the belief with PPH is that it's bad blood that needs to leave the body. That's a major myth, major misconception. telling them that this is life-threatening and that this doesn't need to leave the body is the primary role of the skilled birth attendant to tell women. I mean, it takes 10 minutes for a woman to lose her life. It's that urgent. It's that critical. So then they had to be trained to tell these women, their households, making them aware of all of that. These are some of the socioeconomic constraints that we deal with actively on the ground. Or, men not, or domestic violence, for example, men not allowing women to step out of the house, a host of factors which are realities there,
Yeah, that's true. They're so prevalent and so deep-rooted, but it's really through work like yours and the Mama Baby Fund that I think we are being able to even sort of start chipping away at that massive block. Mehreen, thank you so much for being with me on the show today. And a special shout out to Neha, who we lost halfway thanks to the internet, for being on the show and talking to us about the wonderful work that both of you have been doing. Hopefully we'll get Neha back on another show to make up for the internet eating her up. Thank you guys for watching. If you're watching this on YouTube, don't forget to like and subscribe, and we will see you next time on The Coffee Table. Bye now.